Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
We're going to talk about stroke today, and the two talks that you're going to hear, the first one that is from myself is going to be on risk factors, management and prevention of stroke. So it's a very broad topic. I'm going to give you an overview of everything. And then following me, Doug, our stroke nurse coordinator, he's going to talk about hypertension and give you a whole brief on hypertension, because hypertension is one of the most common risk factors for strokes. So what is stroke? Strokes basically is when there is no blood flow or no oxygen to the cells, brain cells. And when there is no oxygen to the brain cells, they die. Okay. Now, the whole concept of management of stroke is that if you can somehow provide the oxygen and nutrition to the cells as fast as you can have these cells survive, and hence the brain function is maintained. And what we found is that if you do that within 3 to 4 hours, then about 1/3 of the brain function can recover. And that is the basis of our management of stroke today. The major thing that we've learned over the last 5 to 7 years is that if we can give these clot dissolving medicines to dissolve the clot that is causing the obstruction to blood flow, then we can reestablish blood flow and provide the nutrition to the cells. So that is the whole basis of management of stroke today. Stroke is a very common problem. One stroke occurs every 53 seconds, third leading cause of death behind heart disease and cancer, more than 150,000 deaths per year in the United States, more than 750,000 new strokes per year, 4.4 million stroke survivors in the United States, huge population. The most important thing is that it is the leading cause of adult disability, and it's the most preventable of the catastrophic conditions. The mortality from the stroke is about 20%. So 1 in 5 who has a stroke or who has suffers from stroke will not survive it. So a major problem. And there is a substantial morbidity along with survivors. That means 18%, almost 1/5, do not return back to work after a stroke, while 4% are in total custodial care. That means they cannot provide for themselves. This is a very interesting slide. In 1998 it was published, and they asked a very simple question to the patients, that how did they feel after a stroke? And the problem here is that 50% of them felt that it was worse than death. So you can see how disabling the stroke is. And therefore, in the last 15 to 20 years, after we've taken care of heart attacks, and there was a lot of press for managing heart attack patients and stuff, now there is a press to manage patients with stroke, because over the years we've realized that stroke can be prevented, and if treated properly, we can have these patients not suffer a major disabling problem. And hence, there is a lot of work that has been done in the last 5 to 10 years. Like I said, the most devastating is a completed stroke, in which there is paralysis of half of the body or a total disability. And then subsequent to that, or secondary to that, there can be non-disabling strokes. That means patients do not suffer a major disabling problem, but have had a stroke. And the minor forms are transient ischemic attacks, which is patients recover from deficits, which may be a speech problem or weakness of the arms or legs within 24 hours. And that is what is transient ischemic attacks. And also there is another form which is called reversible ischemic neurologic deficits, which means that they do not recover within 24 hours, but over weeks and months, function does recover, and that is a reversible ischemic neurologic deficits. They are all the form of same problem, that is obstruction to the blood flow. And if the obstruction is relieved fast, either by the brain, by the body mechanisms, or by external help, then we can recover most of the function. Less commonly, patients present with vertebrobasal symptoms, which means brain in the stroke in the brain stems, and they come with diplopia, dizziness, dysarthria, visual loss, dysphagia, which means difficulty in swallowing, or imbalance problems. Now, these are all symptoms of stroke which occurs in the back of the brain, not in the front of the brain. Okay. How do we classify strokes? There are two kinds of strokes mainly. One is the ischemic strokes, which is when there is a blood clot that stops the blood flow to the brain. The other is a bleeding inside the brain, and that is called as a hemorrhagic stroke. 80% of the strokes are because of the blood clots. 20% of the strokes are because of the bleeding inside the brain. Of the blood clots, majority of them, 53% of them, are because of a blood clot forms within the artery right there and then. That means a blood clot will form in the brain or in the neck artery and cause the blockage to happen. 30% of them, the blood clot comes from the heart or the major artery called as the aorta, and these are called as embolus. And there are different causes of embolic strokes versus the thrombotic stroke. And that is what I'm going to concentrate on today and try to teach you what is a thrombotic stroke, what is embolic stroke, and what is happening with each of these strokes. On the other hand, the hemorrhagic strokes are because of if there is weakening of the arteries, and that is called as aneurysms. They happen because of high blood pressure mainly, or can happen because of inherent weakness of the artery. Because of the blood pressure, it bulges and subsequently it ruptures, and that is called as an aneurysm. And then there are AV malformations, which are connections between the arteries and the veins, which are very elaborate and become weak, and they can bleed. Now, these are generally patients are born with this rather than they have these formed. Okay. So what happens with these blood clots? How do they form? It is a very simple mechanism, and it's happening all over the body. It just doesn't. It's not just happening in the brain, but these blockages are occurring throughout the body. And what happens is, inside an artery, the lining of the artery somehow erodes. And when the lining of the artery erodes, all this stuff, the cholesterol, the blood cells, the scar tissue, they start accumulating at that lining at the point where there is lining disruption. And as this grows, this plaque grows with all this material, it comes to a certain point where it cannot be contained by the lining. And when that happens, it ruptures. When this lining ruptures, then all the material that has been sort of kept behind by the lining, that erupts into the blood cells, into the lumen of the artery. And two things can happen then. One, this can completely block off the artery. And if that happens, then you get things like heart attacks, strokes, or if it is in the leg, you get gangrene of the leg. So that's a process happening all over the body. Now, on the other hand, if it does not completely block the artery and does partially block it, then you get symptoms of what I talked to you about, TIA, or in the heart you will get chest pain, but not a heart attack, and in the legs you will get pain on walking, but again not gangrene. Okay, so that is what happens. Now, what causes this to be a complete blockage versus partial blockage, we don't know. And these are the lucky people, these are the unlucky people. Okay. Now, this is how it ruptures. That is, all this material accumulates behind the lining, and when the pressure behind the lining increases, it ruptures the lining, and thus all these material, they are freed into the lumen of the artery, and they go downstream and cause the blockage. This is how an artery looks with a blood clot. This is the plaque that I talked to you about, the atherosclerosis, and when it ruptures, it causes the blood clot to form and totally block off the artery. Okay. Now, depending on how bad the blockage is, you see the symptoms. In the brain, normal blood flow is 50 to 55 milliliters per 100 grams of the brain. If it is halved, then you start seeing the effects of dysfunction, brain cell dysfunction. That means the cells are not functioning properly, and when the blood flow is halved. If the blood flow further decreases, then these cells become totally dysfunctional, and that is when you start seeing paralysis, speech problems, vision problems. And if it the blood flow falls below 8, then you see cell death. That means there is no hope for recovery at that point. Anything before this point is recoverable, and that is why establishing blood flow is very important. If we can establish blood flow before it's totally cut off for a while, then we can recover some of the function. Okay, like I told you, this process is happening all over the body. If it happens in the brain, we get transient ischemic attacks or mini strokes or complete strokes. If it happens in the heart, we get chest pains or heart attacks. If it happens in the legs, we get pain in the legs on walking or gangrene. But the same process. And that brings to the thing that if anybody has heart problems, then they should be checked for a risk of stroke or risk of problems with the leg circulation, because they are all related, because it's the same process. Similarly, if somebody's had a stroke, they need to be checked for heart issues. They should be checked for circulation, problems with the circulation in the heart and circulation in the legs. So all these three conditions are interrelated. So when you go to a doctor and you have a problem with the heart, make sure that they've checked you for any issues with the stroke, and I will tell you what they should be doing at that point. Similarly, they should be checking for the kidney artery blockages and the leg artery blockages. The risk of, if a patient's had a heart attack, then there is increased risk of stroke depending on the risk factors that they have. Similarly, depending on the amount of risk factors that one has, and we're going to go over these risk factors in a few seconds, the risk of stroke increases. If you have one risk factor, the chances of having a stroke is 5%. If you have 2 to 3 risk factors, the risk is doubled. If you have 4 to 5 risk factors, it's tripled. And if you have 6 to 7 or more risk factors, then 1 in 5 patients would have a stroke, pretty much guaranteed, if they are not treated well. And what causes death after stroke is mainly the stroke itself causes death in the first 30 days. But subsequently, it is either the infections or heart attacks that cause death. So if a patient survives a stroke, then they need to be treated aggressively for infections and for heart issues, because that is how the patient is going to suffer subsequently. Okay. This is reiterating the same thing, that if you've had a stroke, then you are at a risk of having a second stroke. The risk of second stroke is 9 times greater if you've had one stroke. So preventing a second stroke becomes a key in management of patients with stroke. Similarly, if patients had a heart attack, they are at a 3 to 4 times risk of having a stroke. Okay? And if they have blockages in the leg, they are at 2 to 3 times greater risk of having strokes. So the risk of having a second stroke is very high in any of these circumstances. The problem of stroke occurs later in life. It's not a disease of young people, it's a disease of elderly. And the incidence starts increasing at the age of 55 and subsequently keeps increasing as patients grow older. Okay. Now let's go over the risk factors of stroke. The major risk factor for causing stroke is high blood pressure, hypertension. 35% of the patients have problems with high blood pressure leading to stroke. Heart disease is 10 to 12%. Previous strokes, 2%. Diabetes, 4 to 6%. Smoking is another major problem in patients who have had strokes. And then there is age, sex, race, which you cannot change much. They are risk factors for stroke. And if they've had family history of strokes, then they're at a risk of stroke. The risk factors that can be treated are high blood pressure, heart disease, smoking. If they've had many strokes, they can be treated. Diabetes, high cholesterol or lipid problems, and if they have blockages in the neck arteries. So these are the ones that you can treat, and that is what we concentrate on. The ones that you cannot treat, like age, sex, race, family history, or previous stroke, then you can't, you sort of live with those. Okay. Now, smoking, I'm going to be very short with that. It's a pretty much no-no. There's no benefit of smoking. I don't think so anybody can justify that. And we work hard for people to quit smoking. That is, if they have a drive to quit smoking. If a person does not want to quit, there's no way that you can make him quit or make her quit. But if they want to quit, then we do have a lot of resources. Smoking causes a lot of problems with the heart, with the strokes, with the legs. There's just really no justification for smoking. There are a lot of plans. At Washington Hospital, we have a whole program to help quit smoking, and we have a lot of drugs today that can help with quitting smoking. And some of the drugs are available over the counter. You don't even need to see a physician, and you can get these patches and gums from over the counter and quit smoking. And they do work. That is, if a patient wants to quit. Okay. Second one that I want to talk about is blood pressure. Blood pressure is a major risk factor for stroke. The key numbers that you need to remember is the ideal blood pressure is 120 on the top one, the systolic blood pressure, and 80 on the bottom one, the diastolic blood pressure. That is the ideal number. Okay. Now, as we grow older, the arteries stiffen and the blood pressure starts creeping up. In an elderly person, 70, 75, 80 years old, you can accept a normal blood pressure of 140 or 150 on the top one, but 90 on the bottom one. The bottom number should always remain below 90, no matter what age. The top one can creep up with, as you grow older, and 140 to 150 is acceptable. Okay. Blood pressure, lower the better. Some people have blood pressures of 100, 110 on the top one. That is absolutely fine. The bottom one can be as low as 10, 20, and it is fine, because the bottom one should be less than 90. And sometimes because of some heart conditions, the bottom blood pressure stays very low, and that is okay. There are various studies that have shown that if blood pressure is treated, then we can reduce the risk of heart attacks and strokes. There's umpteen studies, so there's really no debate on aggressive management of blood pressure. Okay. We have a lot of ways of treating blood pressure, high blood pressure. The main one is basically changing lifestyle modification. So changing diet, exercising is a very important thing. If diet and exercise are not working to control blood pressure, and the systolic blood pressure is in the range of 140 to 159, or the diastolic is more than 90, then we start using drugs. And we have a lot of drugs that we can use. We start with a single drug. If the blood pressure stays high, we add more drugs to it. But the important thing of high blood pressure is, and that is what I would like to sort of convey to you all, is that when you have high blood pressure problems and you see your physicians, make sure that they have checked you for other causes of causing blood pressure being high, like kidney artery problems, like hormonal problems, brain problems. You do need to be checked out for those before they start saying that we do not know the cause of high blood pressure. Okay, because 10 to 20% of patients have a problem that is causing high blood pressure. So one should investigate for those, and then if you don't find any of those, then you really can't do anything more than just treating it. Okay. So like I mentioned, weight reduction is very important. Exercise, diet, cutting down on salts, cutting down on alcohol if you drink heavily, and exercising on a daily basis. Okay. We have umpteen drugs, and I'm not going to go over those to treat high blood pressure. Okay. The second risk factor that I want to talk about more is lipid, cholesterol management. It has sort of been a hype now to control high cholesterol. And you see a lot of advertisements. The good thing is that it is beneficial if we can control cholesterol well. Cholesterol has a lot of components. One is a good cholesterol, called as HDL, the bad cholesterol, the LDL, and what I call as the ugly one is the triglycerides. So these are the three major components: the good, the bad, and the ugly. Okay, and the bad cholesterol is called as LDL, and my take is that it should always be less than 100 on the LDL. Now it is difficult. Most of us, in a normal person, young, healthy person, we would say 130 is okay. 100 to 130 level is okay. But in patients who have heart problems, have had strokes, less than 100 is important. And if they have diabetes and multiple risk factors, then the target is less than 70 on the bad cholesterol. Okay. Now these are targets that are not easy to achieve. Okay. So diet, exercise is definitely important. Diet does help with lowering the bad cholesterol, but most of the time you would need drugs. And the drugs, the common ones are statins, and you may have heard about these like Lipitor, Crestor, Zocor, Simvastatin. All these drugs, they do the same thing. Basically, they are statins. Okay, so you need them, and when you use these drugs, remember there are two major side effects of these drugs. One is it affects the liver. Second, it causes muscle aches and body aches. So if you are on these drugs, you need to keep a watch on these side effects. And regarding the liver, the physician will do a test on the liver every 3 months, 6 months to make sure that the liver is not affected by these drugs. Okay, like I mentioned, that the target is less than 100, less than 70 on high-risk population. Okay, the diet in these patients, basically you need to cut down on saturated fats. The tasty stuff, stop it. Okay. Generally, the total amount of cholesterol that you can take is less than 200 milligrams per day. Cholesterol is important, let me tell you that. The reason the cholesterol is important is that because all these hormones in the body, they are formed from cholesterol. So you really can't get rid of cholesterol completely, okay, because these hormones form the important functions in the body. So you do need to take some cholesterol, and but the amount of cholesterol that you need is very little, less than 200 milligrams per day, which means not even a tablespoon. Okay. Adding non-saturated fats is very good. These days, omega-3 fatty acids or fish oils do benefit in decreasing triglycerides mainly, but can help with total cholesterol also. Okay. The good cholesterol number that you need to remember is that it should be more than 40. HDL should always stay more than 40, and the higher, the better on the good cholesterol. The good cholesterol comes up with exercise mainly, and there are certain specific drugs that will bring up the good cholesterol. So good cholesterol, exercise and medications, bad cholesterol, diet and medications. Okay. Triglycerides, again, should be less than 150 generally, and if they are high, then they can be treated easily with diet and medications. The triglycerides, they go up and down very fast. If you've taken a heavy meal the night before, your triglycerides will be high in the morning. Okay, so when you get your blood test done for cholesterol, make sure that you are fasting for 12 hours. If you're not, if you just fasted for 8 hours, the triglycerides might be on a higher level and will give you a higher cholesterol level. Okay. Triglycerides, like I said, are treated with medicines and diet. The there are a number of trials, number of studies that have been done on cholesterol and lowering the cholesterol, and they've all shown that they do help in preventing heart attacks and preventing strokes. So there is really no question asked on whether we should treat high cholesterol or not. In today's day and age, we definitely need to treat it aggressively. Okay. Like I said, there are a number of drugs. Statins are the most common one. They help more with the bad cholesterol, less so with the good cholesterol. Then there are nicotinic acid, niacin, which help with the good cholesterol and less with the bad cholesterol. And in between, there are other drugs that we can use. Okay. Activity, exercise is very important. It helps with all the risk factors. Exercise helps with lowering the cholesterol, lowering the blood pressure, and helping with control of diabetes. So exercise in your daily routine is important. What I recommend is that if you can exercise 5 days a week, and my recommendation is walking 2 miles a day. Whether you walk at a fast pace, whether you walk at a slow pace, if you do 2 miles a day, I think that is enough form of exercise. Some of you would have arthritis and problems with walking, and my suggestion to that is that if you take a pain pill half an hour, 45 minutes before, and then walk. If you cannot walk, then there are 2 other forms of exercise. One is bicycling, second is swimming. Okay, swimming is very good. It helps with the arthritis also. So, in other words, there is no excuse for not exercising. Okay, bicycling is also good. It puts less pressure on the knees and the hips, but exercise is very important. Okay, and if somebody is overweight, then losing weight does help. Okay, there are various measures like BMI, basal metabolic index, waist circumferences, and the key is if you lose weight, that helps with diabetes, high blood pressure, and cholesterol. So all these 3 risk factors are interrelated, and their management is pretty much the same as far as diet and exercise goes, and then the medications are different. Okay. Diabetes, I don't know, this is an older slide and I have not updated it. The key measures for diabetes are checking the fasting blood sugar, and then this blood test called as hemoglobin A1C. 2 to 3 years ago, it used to be less than 7%, which we used to take as an acceptable number. Today, this number has dropped to 6%, because diabetes is thought to be as bad as having a heart attack. So if you have diabetes, then we classify you as having had 1 heart attack already. Okay, so diabetes is treated very aggressively, and you all need to remember that your hemoglobin A1C should definitely be less than 7%, but closer to 6. Okay, and you should get it measured every 3 to 6 months if you are diabetic. Okay, so this phenomenon of atherothrombosis, or building of plaque or blocking of the artery, is prevalent and deadly. Okay, manifestations include heart attacks, strokes, gangrene of the legs. Heart attack and strokes, they form a significant health burden. The atherothrombosis is characterized by sudden blockages of the arteries that rupture and cause complete blockages. And it does need to be treated aggressively by controlling these risk factors. Okay. Now, going on to some other causes of stroke, this is a slide that shows you that the strokes can be prevented, because half of them are caused by high blood pressure. If you control high blood pressure aggressively, you can decrease the chances of having a stroke. Similarly, if you control the cholesterol, 1/4 of them are caused by cholesterol issues, and you can control them. The rest are caused by heart problems and heavy alcohol abuse, which again can be treated well. Okay. The heart problems that can cause strokes is called as an irregular heartbeat, also called as atrial fibrillation. This is when a patient gets irregular heartbeats, and the blood flow to the body is decreased because of irregular heartbeats, And what happens is the blood stagnates in the heart chambers. And when there is stagnation of the blood, then blood clots form in the heart. And when these blood clots are formed in the heart, they get sort of released from the attached tissues, and then they can travel to anywhere in the body. Most of the time, because the brain is right up across from the heart, they travel to the brain and cause strokes. But if they do not travel to the brain, they may go downstream and cause problems with the stomach, problems with the kidneys, or the legs. Okay, so that is called as atrial fibrillation, a very common problem in the elderly. There are 2 to 3 million adults that are living with this problem. As one grows older, the risk of having atrial fibrillation or irregular heartbeat increases just because of degeneration of the heart valves or degeneration of the heart muscle. Okay. 1 out of 6 strokes occur because of this irregular heartbeat. Okay. The stroke risk in patients with atrial fibrillation is twice than in patients without irregular heartbeats, and 15 to 44 patients who would benefit from prophylactic treatment of this problem receive treatment. So that means more than half of the patients are not treated properly when they have irregular heartbeat. If you have an irregular heartbeat, you do need to see a cardiologist, because most of the regular physicians, they are not well aware of how to treat this problem. Okay. The way to treat this irregular heartbeat is by putting patients on blood thinners. Okay. The common one that we use is warfarin. Okay. And the unfortunate thing with when you are on a blood thinner like warfarin is that you need to monitor the blood tests very frequently. Initially every week, 2 weeks, subsequently every month. And the risk of taking a blood thinner is bleeding. So you want to make sure that you stay in a normal range, the range that we want to maintain, rather than being high, because the risk of bleeding increases if blood is too thin. Okay. If you do not have any risk factors and you have irregular heartbeat, then one can be treated with just aspirin and does not need this nasty blood thinner called as warfarin. Okay. So atrial fibrillation is the most prevalent of the cardiac arrhythmias, irregular heart rhythm, with subsequent increase in cases expected over the next 3 decades. And this is because the patient population is getting older and older. Okay. It is associated with more than 5 times increase of strokes. Treating with anticoagulation, that is the blood thinner, is very important because it does decrease the risk of having a stroke, and the risk of bleeding is higher. A few words about aspirin that I want to tell you is that aspirin is an important drug. In my mind, it should be pretty much put in water, because everybody should be on aspirin. It decreases the incidence of heart attacks, decreases the risk of strokes. It keeps the blood flowing in a better shape. And one can stay on a low dose of aspirin. And the dose that we talk about is in the range of 81 milligrams to 162 milligrams. That is an acceptable dose for aspirin. Now, there is another blood thinner that some of you may have heard about it, called as Plavix, which we give to patients after putting stents in their heart arteries, and it is a stronger blood thinner than aspirin. So when we have to compromise between giving a very, very strong blood thinner like warfarin or the Coumadin versus a mild blood thinner aspirin, then the middle of the road is this drug called as Plavix, called as clopidogrel, which is taken once a day, but it increases the risk of bleeding more than aspirin. Okay. Aspirin in various studies have shown to reduce the risk of heart attacks, strokes, either whether they be primary or secondary, and any risk of blood clots being formed in the heart is decreased with aspirin, though the warfarin is better. Okay. So as far as preventing strokes, the risk factor management is very important, and the risk factors we've gone through. Now, the last one that I want to talk about is blockages in the neck arteries, and that is something that can be prevented also. 30% of the strokes happen because of blockage in the neck artery. Okay. And it is very easy to diagnose these blockages in the neck artery. One, if the physician listens to the neck area well, they can prevent, and they can establish whether there is a blockage or not. And some of the times you may miss it, but if somebody's at a high risk or has had a mini stroke, then we should get a complete evaluation of the neck arteries. And these neck arteries are called as carotid arteries. Okay. The way you establish a diagnosis is by listening to them. And if you listen and you hear an extra sound, then one should do an ultrasound of the neck arteries. Ultrasound is a very simple procedure called as carotid duplex ultrasound. Takes about 5 to 10 minutes. Painless, can be done in the office or in the hospitals. It's inexpensive, and it gives a lot of information. It basically, and it's 90% of the time it is very sensitive, and 99% of the time it is specific and telling you how bad the blockage is. The only disadvantage is that if the blockage is high up, or if there is a lot of calcium, a lot of this hard material, then it is very difficult to diagnose at that point how bad the blockage is. The subsequent to that, based on what you find on the ultrasound, one can do angiogram of the neck arteries. Angiogram can be done in 3 forms, either a MRI or a CAT scan, or what we call as a conventional angiogram, that is when we go from the groin, pass a catheter up to the neck and squirt some dye. So those are the 3 ways of doing angiogram. Going inside the artery and squirting the dye in the neck is the most sensitive and specific method, and is the gold standard, but it is invasive. So short of that, one can do a CAT scan angiogram or a MRI angiogram, and they are pretty much good enough to tell you whether the blockages are bad or they're mild. And based on that, one can decide on how to treat it. Now, there are 3 ways of treating these blockages. This is what a neck artery blockage would look like in the neck, and this is the neck artery that goes to the brain and supplies the whole brain. If there's a blockage here, we could fix this blockage either with surgery or with stents, metal coils called stents. And the stenting procedure is new. It's been developed over the last 5 to 10 years, but the results are very good. And I will share some results at our hospital over here. The other way of treating is that if the blockage is not bad, then one can treat with medicines. Generally, if the blockage is more than 80%, then it should be treated with stents or surgery. If the blockage is less than 80%, then it can be treated with medicines. On the other hand, if patient has had a stroke, then anything more than 60% blockage should be treated. Okay. So if somebody's had symptoms, 60% blockage should be treated, 60% or more. If no symptoms, then 80% or more. The way it is done is you pass a catheter up to the neck artery. Then you have a protection device. It's called as an embolic protection device. You thread that through the blockage and you put it up in the brain. This is an umbrella. So what it does is when you open this umbrella, any particles that separate off while you're doing the angioplasty or stenting, they get trapped into this umbrella. So nothing goes to the brain. Then what happens is that you open up this blockage with a balloon, you line it with a stent, and you get a nice good open artery. And once you've done that, you retrieve this umbrella, you collapse it and pull it out. So you take everything out and you leave the stent behind. And the kind of result that you get is what I showed you here. This is a stent that is lining that blockage, and you get a nice clean channel. Okay. The results of this procedure are very good. We have at Washington Hospital been doing this procedure for the last 5 years, and done about 182 cases with various kinds of protection devices. The success rate has been 99%. And complications, we've had 2, with one having a minor stroke, from which the patient recovered completely, and one was a major stroke. The rest of the patients have done very well. This is in comparison to what we've seen anywhere else. Normally acceptable number is 6 strokes in 100 patients. So that is acceptable because the surgeons who do the surgery, their data shows that they cause about 6 strokes in every 100 patient that they do. So our data is much, much better of having 1 in every 100 patient population. The hospital stay is generally one night. They go home the next day and they're completely functional the next day if they've not had any side effects. Generally, these blockages stay open with these stents for a long time. The chances of recurrence is about 5 to 10% in 5 years. 90% of the patient population stays without any recurrence over long term. So overall, the results of the stenting is very good. And these days, we are comparing stenting with surgery, and it is shown that stenting is at least as good, if not better than surgery. So if any of you come across with or have blockages in the neck arteries, you should definitely talk to your physicians about stenting, because it is a newer procedure, so not many physicians are aware of it. So it is important that you look at this option if you are getting treated for neck artery blockages. Okay. Similarly, there is a way to treat blockages in the brain. The way you open up the arteries in the brain is different. You don't put these embolic protection devices, the umbrella in the brain, because these arteries are very small and you can't thread these umbrellas up there. But what you do is you pass a catheter through the blockage and then you suck the blockage out, suck the clot out, rather than opening it with balloons and stents. You generally suck it out, and if you can suck it out and the artery looks good, you don't have to do anything further. If the artery is a little ratty or a little blocked, then you open it up with a balloon, and if then it doesn't look better, then you put a stent in it. The stents that are used in the brain are very different, and it's a very technical procedure. The experience is not that much yet in various centers, but that is definitely an option if we cannot open up the blockage with the blood clot dissolving medicines. The way these blockages are treated is that if you come within the first 3 hours, then you get a clot dissolving medicine that is given through the veins. If you come after 3 to 4 hours, before 6 hours, then what we do is we thread a catheter into the neck artery and give you the clot dissolving medicine in the neck artery. If you come beyond 6 hours, then we do this. We go in and suck the clot out. Okay, so 6 to 8 hours. And if patient comes beyond 8 hours, then we just treat them with medicines and exercise and physical therapy, because beyond that time, most of the tissue damage has occurred and the benefit is very little subsequently. Okay, so that is how the strokes are treated early. What we do also these days is we've developed stroke centers, and Washington Hospital is one of the primary stroke centers in the Bay Area. And what we do is we develop programs that teach people how to prevent strokes from happening, and that is managing the risk factors. Then if they do happen to have a stroke and come to the emergency room, then we intervene in a very expeditious manner, basically making sure that we can dissolve the clot if they are in that time frame, or we can at least send them to a center where they can do these brain procedures, because we do not do the brain procedures at Washington Hospital. We do have links with other centers that can do it, and we transport the patient to those centers for that treatment. And subsequent to a stroke, we want to prevent these patients from having another stroke, and that is called a secondary prevention. And we have a very aggressive program for that. We have a lot of education and a lot of materials that are available to the patient population. Okay. Also, the important part of this taking care of stroke is patient knowledge, and that is why all of you are over here teaching patients how to manage strokes. That is important. And if they've had stroke, then not to wait and watch, but to seek help. And that is where we teach our the EMS services how to manage stroke. So we have classes for the EMS system, and then our hospital is very much geared to aggressively manage stroke in the emergency room, in the stroke units, and there is a whole stroke team that we have. So stroke we take very seriously, and we treat it very aggressively. So the key points are that stroke is preventable. The neural damage, the brain damage after stroke is progressive. So we want to halt that, we want to stop that, and make sure that we can achieve as many of these cells to survive and hopefully recover function. There is a therapeutic window that, like I told you, 3 hours, 6 hours, 8 hours. Stroke is definitely an emergency, and it's not a wait and watch thing. Effective therapies are currently available, and there are very many new treatments that are going to be developed over the next few years, because stroke is definitely taken very seriously these days. Thank you.
So thanks very much for coming. Congratulations for coming, because it shows a real interest that you have in taking care of your own health and taking responsibility for these sorts of things. It's going to benefit you in the long run, that sort of an attitude towards your own health. So thanks very much. You came out on a beautiful day today to see this. So I am Doug Van Houten. I'm a stroke program coordinator, so I see lots and lots of stroke patients here. And one of the main things that I am so incredibly impressed with is that most strokes can be prevented. Most strokes can be prevented, and high blood pressure is one of the really big things. So let's get started and talk about this program here. First of all, I'm going to be very basic. I want to tell you, I want to ask you, what is blood pressure? Do you know exactly what it is? So I have a diagram right here, and this is a diagram of an artery. And what we're talking about is we're talking about the pressure within all of your arteries. Blood pressure is the force of blood against the arterial walls. So think about a hose. You've got a certain amount of pressure in a hose, and if you're holding that hose, water comes out. Maybe it goes a couple of feet out. If you put your finger on the end and you tighten down the diameter of the end of that hose, water goes a long distance. And that's just showing a little change in the pressure there. The way we express blood pressure is in millimeters of mercury. And I want to show you another diagram here. This bottom tracing here is the kind of thing that we used to do in the intensive care unit all the time, because we would measure blood pressures consistently and regularly with patients that were really critical. And so there's always two numbers to blood pressure, right? They're both important. The big number is called systolic blood pressure, and that's the pressure when blood is being forced through, when the heart is contracting, and the big surge of blood through the vessels. And then the heart's got to fill, and so it relaxes in between, and then you've got a lower pressure. Both of those are important. But here's an example of 120/80. So what do all these numbers mean? You hear a lot of different things. One thing that's very clear is that as we age, our blood vessels become more and more stiff and non-compliant. And with that, blood pressure tends to go up. But let's talk about sort of the normals that we see out there. The normal blood pressure that the American Heart Association and most associations like that suggest is that your blood pressure be less than 120/80. Now that gets harder and harder the older we get. Pre-hypertension is 120 to 139/80 to 89. Don't worry, there won't be a test on this in the end. And the first stage of hypertension is when you get over 140/90. So that means you're definitely in high blood pressure there, and you're in a really serious high blood pressure or hypertension when that's above 160/100. One more thing I want to tell you about blood pressure is that your blood pressure sort of rises and falls a little bit during the day. Early in the morning, it's usually lower. Later in the afternoon, it's higher. But what we really try to look at is the average of what it is. And generally, for the average person, if you can get your blood pressure below 120/80, that's probably best. Let me give you a few of the statistics here. There are 65 million Americans with hypertension. So that's really a lot. 1/3 of us don't know we have it. 1 billion people worldwide have hypertension. So it's not just a national problem, it's a global problem. and it accounts for 27% of all the deaths of women and 37% of all the deaths to men. So usually you don't just die of high blood pressure or hypertension. What you're dying of is the disease processes that it creates. So we're talking about coronary artery disease, so people have heart attacks, right? Or we talk about strokes, which I'm very familiar with, or we talk about heart failure. And heart failure is the people that have a heart that doesn't pump very well. It pumps too weakly, and fluid backs up in your system, and you get swollen ankles and fluid in your lungs and that sort of thing. But here is a little, if you look up here, it's a little bit of a cost analysis of how much these things cost. Boy, we're starting to talk about real numbers here when we're talking about 142 billion, huh?
Annually?
That's annually, yeah. I think our government could use some of that money right now. So let's talk about some of the effects. I think hypertension affects many, many things, but let me go over 3 or 4 of the most important ones. And we're talking about chronic high blood pressure. We're talking about this pressure that is a problem day in and day out, decade in, decade out. So certainly stroke, and stroke is where you get a blood clot to the brain because your vasculature has been damaged by high blood pressure. Or you could get coronary artery disease, which causes heart attacks, certainly if not the major killer in this country. There's heart failure, which we talked about, and also kidney damage. In essence, what we're talking about is if you've got too high of a pressure in the system, it's sort of working on all these organs and it's blowing out all these organs. It's just overworking them until they want to succumb before you do. Probably high blood pressure is responsible for 35% of ischemic strokes. That's the most common type of stroke. 56% of all kidney disease is related to high blood pressure. You don't want to lose your kidneys. And look at heart failure. 39% of the heart failure in men is due to high blood pressure. And look at women. Look at this, this gender difference here. 59% of the heart failure in women is due to high blood pressure. So ladies, that's something to really keep your eye on. And if you can lower your blood pressure and keep it down, you can reduce mortality and disability in all of these conditions. I want to do a little bit more of the definitions here. You may hear the term essential hypertension or primary hypertension. 95% of that time, this is what we're talking about. And there's no particular medical cause. It's just the general sort of high blood pressure that people have. There is something called secondary hypertension, which makes up about 10% of these cases, and sometimes those are brought on by different kinds of medications, or you've got a hormonal imbalance, something like that. So essential hypertension is what we're usually talking about. I'm focusing and drilling down even more to where we get to the point where we talk about what can we do about all this. But I just want to let you know that there are 3 major components here of high blood pressure. Number 1 is the heart, which I think of as the pump. It's the thing making this pressure for the most part. Then there's the plumbing, that's the arteries. And then there's the fluid flowing within them, which is the blood volume. And the reason I'm telling you these is a lot of the things, a lot of the medication therapies and a lot of the therapies to reduce blood pressure are related to one or more of these separate aspects of the heart, of the blood pressure. And one last thing is that when you have high blood pressure, think about what your heart's doing. Your heart's beating about 100,000 times a day. And when it's got high blood pressure, it is like this mini jackhammer just hammering away at your organs, like your kidneys, like your brain, like your heart. So it just keeps going and going. So now let's get into this phase here about how can we lower blood pressure? And my talk will be a little bit different than Dr. Jain's because it is less medical oriented, like in regards to pills and medications and things like that, and more lifestyle oriented. What are the things that you can do on your own? And what I'd like to empower you with a little bit is the concept that you can make changes to your blood pressure and bring your own blood pressure down with things that you can do on your own and not necessarily depend on medications. I mean, medications are a great thing, but wouldn't you like to take, say, less of a dose or fewer medications? I mean, it'd be cheaper, you'd just generally be better, it'd be a good thing. So, the first way that you empower yourself is that you know your own blood pressure. And how do you do that? You buy one of these simple blood pressure machines that you can get at a drugstore, at Costco, something like that. And these things are pretty darn accurate. A big study just came out to say, this was in a journal called Hypertension, and it says, there is good evidence that the measurements taken at home by patients are lower than those taken in the doctor's office and closer to the real blood pressure, which is the best predictor of cardiovascular health. So really, that blood pressure you take at home is probably more genuine to what your blood pressure really is. So what I always tell people that have blood pressure problems is get yourself a machine, and then when you do that, do one more thing. Get a little journal and write down your blood pressure every day. And you'll see, you know, one time it might be 125/85. The next time it might be 132/87. Whatever. These things are going to vary back and forth a little bit, but you'll be able to see what your trends are. And if you take that into your doctor's office, they'll be able to look and see exactly where you really are. Any of you know what the term white coat hypertension means? It means you go into your doctor's office and all of a sudden this big doctor walks in wearing a white coat and everything and says, well, what's your blood pressure? You know, and whew, it's through the roof. So it's not really accurate, you know. I mean, it's accurate for that time, but it's not what's going on with you regularly. One thing that I recommend is you can bring your machine in with you, and when they take your blood pressure there, then you take it with your machine as well, and you can sort of correlate to see if your machine's really accurate. These are a couple of the machines right here. Any of you have some of these machines? Yeah, good, a lot of you, see. This is a group that's empowered. They're going to do something about their health. Well, there's two here, and I've said one's best and one is okay. And that means that one's a little bit more accurate than the other. And the one that goes on your arm, even though it's a little bit more difficult to work, is usually a little bit more accurate than the ones that are on your wrist. And there's actually, any of you that have one for your wrist, don't get rid of it. You can still use it. But when you take your blood pressure, you want to have that blood pressure machine be at about the same level as the heart. So I usually ask people to hold it up or put a couple of pillows to hold it up like this. See, when you have one of your blood pressure on your arm, it's always at the level of your heart, right? But if you have your hand down here, it's going to be a different number. Or if you have your arm up here, it's going to be different. So if you're going to go out, I recommend you get one for here. Here's one of the really big things and big lifestyle things that you can do to change your blood pressure, and that is maintain proper weight. 2/3 of us Americans are overweight or obese. You know, if you have 3 people in a room, 2 of those people are overweight in the United States. It's really a tragic sort of thing. It's very much related to high blood pressure. In fact, there is something called the 2-pound rule. Anybody heard about the 2-pound rule? It basically says that for every 2 pounds that you lose, you'll probably drop your blood pressure by 1 point. So let's say that your blood pressure averages out about 140/90. Well, we learned earlier that you're clearly hypertensive at that point. But let's say you're 40 pounds overweight. So you you get your diet worked out so that you get your blood pressure down or get your weight down, and you drop 40 pounds, you probably will drop 20 points on your blood pressure, and now you're 120/80. You're perfect, right? I mean, this is a generalization, but that's generally what we teach people. And I want to tell you a little bit about how you figure out if you're the right weight or not. I mean, a lot of people say, "Oh, you look fine," you know, or "Oh, you're too heavy," or "Oh, you're too not so heavy." And so we have something here. This is called the body mass index chart. And I had passed out some here originally, and today we're going to calculate my body mass index. So this is a little bit easier to see than the ones that you have, but if you look down the side here on your left, you'll see weight in pounds, every 5 pounds. And so that's weight. And then across the top is height. So this is an objective scientific way of determining whether you're the proper weight or not. And if you look on here, now I've been too cheap and I only did black and white handouts for you, but if you look in this area in the green, that's what normal weight is. And if you look up in the blue, that's too light, you're underweight. If you look in the yellow, that's overweight. And the red, boy, that's obesity. And there are numbers there. And the number that you want to try to calculate here is you want to be below about 25. This is a calculation number. And so I'm going to walk over there and I'm going to show you. I weighed myself this morning. I'm 180 pounds and I'm 6 foot 1 inches. And so if I were to measure this, and I'm going to walk over there, I hope that this will be able to, I'll talk a little louder. Here's 180 right here. This is where I am. So you go all the way across, and I'm going all the way across here, and there's 6 foot 1. And so my number is 23.7, and it's in the range of normal weight. So lucky me. I'm just barely into that range. Now, so what you all can do is you all know your height, and you find your height wherever it is on there, and then you come down and you look and see what weight is going to be a reasonable weight for you. So it looks like I could even go up to, I could even come across here at, I could go down to 185 here and go all the way across, and I'd be 24.4. I'd still be okay. So I've got a little buffer. So do you think you could figure out your own weight according to this and your own body mass index and see if you're in the right zone? I'll be around afterwards if you want to go over it. Let's move on to something else, and that is physical activity. Does everybody here exercise every day? Good. See, I knew you were an empowered group. Okay. Well, physical activity is really important. They want you to do 30 minutes of aerobic exercise every day. And so it's not, you can't just say, oh, well, I walk a lot at my work or something. This needs to be focused exercise where you go out and you say, okay, I'm going to walk around Lake Elizabeth, or I'm going to walk here or there, whatever. And you do it at a good pace, a brisk pace. You don't have to kill yourself. 30 minutes is what's recommended every day. So aerobic exercise is exercise that really gets your heart going. So I'm not talking about weightlifting. I'm not talking about archery. I'm not talking about things like that. I'm talking about swimming, walking, jogging, bicycling, that sort of thing. It's, you know, constant movement. You get your heart rate up and you keep it there for a while. That's aerobic activity. Sometimes people ask me, well, how do I know if I'm working hard enough at it? Dr. Jain's got the easiest idea. He says, if you can walk 2 miles every day, you're getting enough exercise. So if it takes you an hour to do it, okay. If you can do it in 15 minutes, okay, that's enough. So, so that's what he says, if you can do that. That's probably about the distance around Lake Elizabeth, if any of you ever go out there. Sometimes they say, well, you walk fast enough so you get a little bit of a glow of perspiration on your forehead. You should be able to talk to somebody while you're walking. And if you're at the point where you can't talk to them while you're walking, you're probably pushing yourself a little bit too hard. So that's the talk test. Is there anything wrong about pushing too hard? Well, you don't want to, I mean, you want to do things that your doctors say is okay. This is, all I'm saying is, this is all you need to do to really reap the benefits. At one time I used to say, gee, a marathon runner ought to be really, really fit. Turns out they're not necessarily any more fit than somebody that gets out and walks regularly like this. They can, you know, they can go faster, but I mean, are they healthier in the long run? Not necessarily. So really, that's probably good enough. Now there is another way that you can figure this out. You can take the number 220 and you can subtract your age, and then you can multiply that number by 0.6 and by 0.8. And that'll give you 60% and 80% of your optimal heart rate. So if you know how to take your heart rate, you can do it that way. Now I worked it out for me. I'm 55, and it turns out that I can just a little bit under 100 and just a little bit over 125 or so is sort of my optimal range. So I'm going to move on from exercise now to smoking. Smoking's a really tough thing to quit, really tough thing to quit, and I want to give that to people who are smokers. But on the other hand, it's one of those absolutes. You just got to find a way to do it. There are some programs at Washington Hospital that will help you quit smoking if that's an issue you have. But it accelerates this whole process of blood vessels breaking down and increases blood pressure. So it's very contributory to heart disease and stroke and kidney disease. How about alcohol intake? Any of you ever heard that alcohol is a good thing for your general health? Yeah, you get studies out here quite often. But the issue is that excessive alcohol intake can run you in the wrong direction and make you hypertensive. And so what is normal, what is moderate drinking? The American Heart Association, their advice on drinking is, if you do not drink right now, probably best not to start. There are too many other health problems along the way for a minimal benefit. If you already drink, make sure that you're drinking at a moderate level. And this isn't going to sound fair, but the American Heart Association says men can have 2 drinks and women can have 1. Yeah?
Sexy is illegal, isn't it?
Is sexism illegal? Yeah, I guess so, but that's the recommendation. It didn't come from me.
Is it like 4 ounces, 6 ounces? What?
Well, that depends. It depends on the percentage of alcohol in your drink. So what they mean is like 1 12-ounce bottle of beer, 1 6-ounce glass of wine, or 1 1.5 ounce jigger of some sort of distilled spirits. So you could have like 1 highball or 1 6-ounce glass of wine or 1 beer. And I find a 6-ounce glass of wine doesn't look very big when I pour it. I mean, it's only about that far right there. So you have to measure these things. I measured it one time. I was a little surprised. Yeah. Okay. Avoid drugs. You don't look like a big drug-taking crowd, but I'm going to tell you anyway. Stimulants such as cocaine, methamphetamine, and that sort of thing are just horrible for strokes and heart disease. And I will tell you, I've had a number of patients that I've seen in the emergency room and followed through that were as young as 21, 23, 25, and they used these drugs and had their whole carotid artery block off, and they have a horrible stroke. So these drugs are very dangerous, and they may be fun and exciting, I don't know, but they're very, very dangerous for blood pressure because they make tremendous surges in blood pressure. And that's where you really get these strokes and things. Now, you have to be careful even for some over-the-counter drugs. Any of you have ever heard of pseudoephedrine? It's a decongestant. Yeah. Well, pseudoephedrine can get your heart rate and your blood pressure up as well. So if you've got issues with blood pressure, a lot of these common cold supplements that they have over the counter, it might be a good idea to talk to your doctor about whether you should take it or not. Also, reconsider alternatives to oral contraceptives, because in even in pretty young people, oral contraceptives can induce hypertension, particularly in women who smoke. And in fact, oral contraceptives and smoking is a deadly combination. Women over the age of 30 who do so are 22 times more likely to have a stroke than normal. So these things are, that we sort of take for granted, you have to be careful of. Avoid stress. Oh, that's easy, right? So stress is something that we try to avoid. The best thing I ever saw was they said, how do you know if you're really stressed out? And generally the thing is, if you think you're stressed out, you probably are. You probably got too many things going on that way. Is there anything you can do about it? There are a few things. Exercise is really good to reduce stress. There are things like yoga and meditation that are specifically focused on relaxing and reducing stress in your life. Whatever you think really makes your life feel right. I always think about my nursing instructor back in the Stone Age. She said, the one thing that keeps me really not stressed out is that I don't get to do really nursing care anymore. And she said, one of the things I do every time we do our clinical is I go in and I tell the nurse, I'll give your bed bath for you today. She says, I love that, and that just makes my day all right when I do that. So maybe you've got a favorite TV show that relaxes you and puts you in the proper frame. Maybe taking a break to read something, taking a nap, something like that. I'm not very good about taking my breaks at work, but I think I'd be better if I took my breaks in a regular time zone. I think it resets your stress clock, if you know what I mean. I always try to tell people, don't sweat the small stuff. And a lot of times we get very stressed out by little things. I mean, think about how far you've come in this life, and you've gotten by all these stressful issues all along, so you might as well be confident that you're going to continue to do so, and why worry about it? So easier said than done, but a couple of thoughts on that. Any of you ever heard that salt in your diet is bad for blood pressure? As it turns out, it isn't so for everybody. About a third of us are specifically sensitive to the sodium in salt, sodium chloride, right? So about 1/3 of us are sensitive to that, and it causes high blood pressure. So nonetheless, it's probably a good thing to avoid and not to get too involved with. Turns out that 15 to 20% of the sodium you get in your diet is from the salt shaker. Everything else comes from the food that you choose to eat. So what does this say? To me, it says you've got to be careful and read labels and know how much sodium's in your diet. When we put patients on low sodium diets in the hospital, typically it's about 2 grams or 2,000 milligrams. So you just got to figure out how much sodium is in things. What I've been really impressed with is that things don't have to taste salty to have a lot of sodium in them. I'll give you a couple of examples. Tomato juice is full of sodium. A lot of bakery goods are high in sodium because what do they use? They use baking soda and they use baking powder, which are high in sodium, as a leavening agent. What are some other things? White bread is very high in sodium, and it doesn't taste salty. So you can't just say it doesn't taste salty, it's okay. You have to learn to read those things and figure out what they are. I'll tell you one other thing is food that comes in cans like If you had a choice between canned peas for your dinner or frozen peas, well, canned peas have a lot of sodium in them. They use salt when they cure that and put them in a canning process. Frozen peas, they really just sort of wash them off and put them in a container and freeze them. So frozen foods are better. Let's see. Most Americans take in more sodium than they should. Men take in about 4,200 a day and women about 3,300 a day. And the recommendation here is that if you, the average person, I think about 1,500 milligrams to 2,300 milligrams is probably about right. And if you were to figure out how much salt that is, if you were to take a teaspoon and fill that up with a salt shaker, that's about how much sodium you should have in a whole day. So, I mean, it's a pretty small little container that way, but there's lots of sodium in foods. So, reduce sodium intake. Learn to read labels. Avoid going out to eat a lot. It's fun to go out to eat. I mean, we go out for social reasons, you know, meet somebody for lunch, that sort of thing. But what they do in restaurants is they usually heavily salt foods. They want food that tastes good so that you come back. Learn the high sodium foods, which we talked about. Try to choose natural foods, unprocessed foods. So, you know, have fresh fruits and vegetables, those sorts of things, or frozen. Try to avoid the canned ones if you can, or commercially processed foods. Definitely don't go out for fast food every day. Fast food is just really full of sodium. Now I want to tell you about something, and this is what this is. This is called the DASH diet. Any of you ever heard of the DASH diet? Well, DASH stands for Dietary Approach to Stopping Hypertension. And this is not a little fly-by-night diet that comes out. This isn't the South Beach diet or anything like that. This is a diet that is supported by the government, and they say this is a really healthy way to eat. And if you can see the foods that are up there on this picture, it is fresh fruits and vegetables and whole grains. That's the big emphasis on these on this diet. If you go to the internet site, and I have a couple of these that I've printed off here, so if I'm willing to give these away a little bit later on. This is a whole 65 pages of the DASH diet. If you go to this website or look on this, you'll find the different food groups that they think is more important to eat. And what you'll find is whole grains, vegetables, fruits, low-fat dairy products. And what is minimized is things like meats and poultry. You just don't need that much of that. Nuts, seeds, and legumes are good. Legumes are another word for beans and peas and things like that. What these things tend to do is they tend to change your metabolism a little bit to being a little bit more potassium-based as opposed to sodium-based. And they usually expect that you will start to get a change in your blood pressure within a couple of weeks. So you have to be on a diet like that. This is another picture that they have here. You can see in the very top there's just a very little bit amount of sweets on top. Beans, nuts, and seeds, oils and salt, salad dressings, mayonnaise, those are small amounts. But down on the bottom, fresh fruits and vegetables, that's the big thing. So if you can focus on those, they're talking about 8 to 10 servings a day. Anybody know how much a serving is usually? It's about the size of your fist. So if you're a real big guy, you've got a bigger fist, you've got a bigger serving. If you're a little tiny person, you've got a smaller fist. And that's the way to think about that as far as just volume. At least that's what the dietitians tell me. And here's one of the other ones that I think is sort of interesting. Are you getting good enough sleep? I want to tell you a story using my wife. I got permission to tell this story. My wife, about 5 years ago, when she had turned 50, she started to have migraine headaches, and her blood pressure started to go up, and she was tired all the time, and I just couldn't quite figure that out. In the meantime, I noticed, boy, she'd really started snoring loud. She was waking me up at night, sleeping with a pillow over my head. And so we finally got her for a sleep study. And a sleep study found that she had severe obstructive sleep apnea. And she was waking up as often as 60 times an hour during the night. Just wake up very briefly and go back to sleep. And what happens is every time you wake up, it's like getting a little jolt. You get this adrenaline flowing, and this tends to lead to high blood pressure. And people that have obstructive sleep apnea have many more heart attacks and strokes. People that have sleep apnea sort of have characteristics generally of having a short, large neck. So men usually know their neck sizes, and if their neck sizes are large for a shirt, for a collar, those are that way. People that are a little overweight, and any history of loud snoring. So these are some of the signs and symptoms that way. And you know, your physician doesn't sleep with you at night, so he's not necessarily going to know what's going on with you that way. So the best person is your spouse to tell you whether or not you're snoring a lot. And this could be a problem there. There are some answers to this. My wife got one of these CPAP machines. It's a little mask that goes over her nose, connects to a very quiet little machine about the size of a shoebox, and it puts some positive pressure in there, and it completely stops snoring. And the first night she slept with one of those, she woke up in the morning and says, I can't remember when I woke up feeling more refreshed. So, and in a very short time, she got off her medications for high blood pressure. So it's something to think about that's you don't normally think about. Last but not least, I don't want to avoid medications altogether. Medications can be your friend. They're the things that are really, you know, once you've tried all these other things, they're the things that are going to really be able to get your blood pressure down and keep you from having a heart attack or a stroke or kidney disease or whatever. And these are some of them. I don't know if any of you are on them. There are diuretics, sometimes called water pills, Lasix, furosemide, hydrochlorothiazide. And what do? They reduce, remember I said there were three components, the pump, the plumbing, and the fluid volume. They reduce the fluid volume. Beta blockers, probably a number of you are on metoprolol or Lopressor. That's a common one. Atenolol, Coreg. Those sorts of drugs, actually hydralazine isn't, but those other drugs there, what they do is they tend to relax the blood vessels. So they work on the plumbing. So you can widen out those blood vessels a little bit and reduce the blood pressure. Calcium channel blockers, amlodipine, verapamil, those things do the same thing there. ACE inhibitors, again, work on your blood vessels. So really important to follow your doctor's recommendations. Here's a really fascinating article that just came out in 2009 in the British Medical Journal, and it basically recommended blood pressure medications for everyone. And it basically said, their impressive sentence here was, whatever your blood pressure, you would benefit from lowering it further. Everyone benefits from taking blood pressure lowering drugs. There is no one who does not benefit because their blood pressure is so-called normal. So it's just a general thing that says it seems to be that the lower your blood pressure is, probably the less likely you will have problems with stroke and heart attack. So if you're on medications, don't feel too bad about taking them. I'm not suggesting that everybody go out and get them, but I just wanted to give you that opinion after a very big study. A little bit of blood pressure medications can really be helpful. Antihypertensive medications can save your life, and that's what I'm trying to say. They can also have some side effects. So I know you want to get off these medications, or at least some of them, if you can. And I've talked about a lot of lifestyle changes that you could instigate yourself to try to bring your blood pressure down, because some of the side effects include fatigue, particularly with the beta blockers, exercise intolerance, the diuretics have you running for the bathroom all the time. You can have cough, erectile dysfunction. But this is the philosophy that I think ought to be the take-home message, and that is, take your medications if they're prescribed. In the meantime, work on the lifestyle changes to lower blood pressure that you can. And if you can get your blood pressure down even lower because you've lost weight, you've changed your diet, you've stopped smoking, those sorts of things, maybe you can get off those medications. Maybe you can cut the medication down by half. But whatever you can do, this will empower you further to get even better. Here's a few more thoughts on blood pressure, and that is that high blood pressure, the rate, the older you get, the more incidence of high blood pressure. Remember I said blood vessels get more and more non-compliant and more stiff. And so it goes up with age. So, you know, that's why we don't have too many people, too many teenagers with hypertension. But as we get into our 70s and 80s, it's much more common. And so you have to keep an eye on that. And as this blood pressure goes up, the higher your blood pressure gets, the more problems you have with heart disease, stroke, kidney disease, all those problems. So you really want to, I wouldn't settle for a blood pressure that's just sort of not too high. I'd like to get it down even a little bit lower than expected if I could. Few more thoughts. African Americans and blacks from Africa have a bigger problem with blood pressure. It's just part of the genetic makeup. They tend to have to use more medications to get their blood pressure under control. And I think the reason for mentioning it is that if you're African American, you have to be a little bit more cautious about your blood pressure. I would absolutely get a blood pressure taking machine if I was African American, just to follow that more closely. And how about hypertension in women? I already talked about how it was almost twice as likely to cause congestive heart failure in women than it was in men. So there are some gender differences there. And here is an interesting article that just came out. They took 83,000 women and they measured blood pressures from the beginning, and then they asked them about lifestyle changes that they made. And then they went through and they looked at all the things that those women did, and they ranked the 6 best things that they could do as far as lifestyle changes to reduce blood pressure. Right on top, the #1 thing is lose weight. So get to be your optimal weight. That's the #1 thing that women can do to have a big outcome. And remember, hypertension contributes to more excess deaths in women than any other preventable factor. So really, if you can lose weight, that's a big deal. The next one is 30 minutes of exercise every day. So brisk walking or swimming, something like that. #3, have a good diet, like the DASH diet. That's a good one that's low in sodium and is going to help you lower your blood pressure. And #4, control the use of alcohol. So those are the 4 top things that women can do to lower their blood pressure to have as far as a lifestyle change. Now there's 2 that were new to me, and one is reduce the use of non-narcotic analgesics. So Tylenol, aspirin, Advil. And when I spoke to a pharmacist about this, she said, well, you know, the one that's really there is the Advil, the ibuprofen, because it tends to cause more sodium to be in your system, and that will raise blood pressure that way. So that's the one right there. The other one is increase your folic acid intake. And apparently, folic acid tends to make your blood vessels a little bit more compliant and a little bit softer. and that will lower blood pressure in that way. And I heard Dr. Jain talk about folic acid. But think about these 6 things. Control weight, get your exercise, have a good diet, control the use of alcohol. Those are the really great lifestyle changes that I think women can make in particular to turn their blood pressure around. Other people that need to be particularly vigilant with blood pressure are diabetics. In fact, I heard, I've seen a number of talks on diabetes and blood pressure, and they kept finding that there was almost not a level too low to get an additional benefit with regards to strokes and heart attacks. So, you know, if people could get their blood pressure to 140/90, they'd have a lot of benefit. If they could get it to 120/80, they could have a lot more benefit. If they could get it to 100/70, even that much more benefit. There was almost not a too low level. I guess the way to think about it is the lower you can get your blood pressure and still function well, the better. People with cardiovascular disease already or strokes already, they really need to be careful. Chronic kidney disease. So everybody needs to be careful about their blood pressure, even this little cat.
Thank you.
Thank you for coming.